Hello, my name is Kelly Elchman, and I am a fourth-year medical student at the Boston University School of Medicine. In this program, Dr. Rafael Ortega, a member of our faculty, and I are going to describe, in broad terms, how general anesthesia is frequently administered today. A student's first exposure to anesthesiology can be daunting. The operating room is a complex environment where multiple activities often occur simultaneously, and it is easy to get distracted. The anesthesiologist's role is to exercise absolute vigilance to safely prepare the patient for surgery, ensuring amnesia, analgesia, immobility, and frequently muscular paralysis throughout the surgical procedure. The aim of this presentation is to explain an approach to the administration of a general anesthetic with endotracheal intubation, and to demonstrate a few commonly used techniques. While this process varies among anesthesiologists and from one surgical procedure to the next, understanding the basic principles involved is an important first step for beginners in anesthesiology. Every anesthetic begins with the evaluation and preparation of the patient for both the anesthetic and the surgical procedure. Usually, on the day of surgery, the anesthesiologist who will administer the anesthetic meets the patient in the preoperative holding area. Here, he or she reviews the anesthesia evaluation, which is frequently completed several days before the procedure, and introduces him or herself to the patient. Healthier patients, or patients requiring urgent procedures, may be evaluated for the first time in the holding area. Thus, either the pre-existing evaluation is updated the day of surgery, or a new evaluation must take place. Now, Dr. Ortega will explain what is involved in the preoperative evaluation.
The preoperative evaluation can be seen as a history and physical exam geared towards anesthesiology. With this tool, the anesthesiologist determines how any medical condition, medications, previous operations, the physical exam, laboratory data, and other variables may impact the anesthetic management. It is important to obtain an accurate history of any problems related to previous anesthetics, as well as any past or current cardiac or pulmonary issues. During the physical exam, the anesthesiologist emphasizes assessing the anatomy of the airway. The aim of this examination is to identify features that may present difficulties in ventilating a patient with a face mask or difficulty performing a direct laryngoscopy and endotracheal intubation.
You may wonder, what happens in emergency situations when there is no pre-existing anesthesia evaluation and time is of the essence? The answer is that an anesthesiologist must rapidly assess the patient's condition and swiftly perform procedures required to anesthetize or resuscitate the patient. The point is that regardless of the urgency of the procedure, a pre-anesthesia evaluation must take place. After completing the preoperative evaluation, the anesthesiologist obtains informed consent from the patient. This process requires describing, in lay terms, the purpose of the anesthetic and explaining possible alternative methods, as well as detailing the risks and benefits of each approach.
The patient must understand the implications of the anesthetic. Some patients may find the explanations unsettling. This is why it is important to answer all questions in a reassuring and calming manner. Indeed, this is where the anesthetic begins.
The next step is to obtain peripheral intravenous access. Usually, a peripheral intravenous catheter is inserted prior to the induction of general anesthesia. The size and placement of the catheter depend on the nature of the surgical procedure as well as the patient's vascular anatomy. Usually, the first intravenous catheter is placed in the preoperative holding area. A second catheter may be placed in the operating room after the patient is anesthetized. However, occasionally, such as in the case of an uncooperative toddler, it is necessary to induce general anesthesia first using an inhaled anesthetic, and then to insert a peripheral intravenous catheter. The anticipation of a surgical procedure can be anxiety-provoking in many patients. Helping to ease this anxiety is an important part of patient care in anesthesiology. What can anesthesiologists do to allay patients' preoperative apprehension?
In addition to reassuring the patient and establishing rapport, anesthesiologists frequently administer intravenous anxiolytics before transporting patients to the operating room. The most commonly used drug for this purpose is midazolam, which is marketed as Versed. Midazolam is a short-acting benzodiazepine with strong amnestic effects. Depending on the surgical procedure and the patient's medical condition, other premedications in addition to anxiolytics may be indicated. For example, a patient having oral surgery or airway instrumentation may need an antipsyllog such as glycopyrrolate to reduce saliva production. Similarly, patients prone to post-operative nausea and vomiting may be given an antiemetic prior to anesthesia. And patients with history of bronchospasm may be given an inhaled bronchodilator while in the holding area.
After all of the preoperative requirements are fulfilled, the anesthesiologist transports the patient to the operating room on a stretcher. It is important to prevent injury to the patient during transport and transfer to the operating table. Hands and elbows must be within the side rails of the stretcher at all times during transport. The anesthesiologist monitors the patient, assessing the effects of any medication that might have been administered.
A critical step is to transfer the patient from stretcher to operating table. To avoid accidental falls, which may lead to serious complications, both the stretcher and the table must be locked in position. Here, good communication is imperative. There should always be at least one person standing next to the stretcher and another next to the operating table, not only to assist in moving the patient, but also to minimize the possibility of an accidental fall.
Once the patient is on the operating table, the anesthesiologist begins connecting the patient to the monitoring devices. What devices are necessary for monitoring the patient throughout a general anesthetic?
Anesthesiologists routinely use an electrocardiogram, a pulse oximeter, and a non-invasive automatic blood pressure cuff. The color-coded electrocardiogram leads must be positioned correctly, according to standard guidelines, to obtain an accurate reading. Occasionally, these leads are placed in unconventional locations due to the nature of the surgery or the positioning of the patient. Anesthesiologists also frequently use an esophageal stethoscope equipped with a temperature sensor, which is inserted after the induction of anesthesia. This device can be used both to auscultate breath and heart sounds and to measure the patient's temperature.
Now that the monitoring devices have been connected, the anesthesiologist can monitor the patient's blood pressure, heart rate and rhythm, blood oxygen saturation, and temperature throughout the anesthetic. Is the patient now ready for induction of general anesthesia?
Before the patient is ready to receive the anesthetic, he or she must undergo pre-oxygenation. This process, also known as denitrogenation, consists of the patient breathing 100% oxygen to replace the existing nitrogen in the lungs and increase the oxygen concentration in the lungs and tissues.
Pre-oxygenation has several benefits. Having the patient breathe 100% oxygen for 3 minutes or more increases the oxygen content in the tissues and allows the patient to remain apneic for a longer period of time than would be possible without pre-oxygenation. This provides additional time for airway instrumentation, if necessary, and minimizes the possibility of hypoxemia. While delivering oxygen to the patient with a face mask, it is important to assess if the patient is indeed being adequately pre-oxygenated.
The signs of inadequate pre-oxygenation include visualizing fog on the face mask, movement of the reservoir bag, the appearance of a capnograph tracing, increasing of the hemoglobin oxygen saturation as measured with the pulse oximeter, and the equilibration of the expired and the inspired oxygen concentrations. Pre-oxygenation plays an important part in the administration of a general anesthetic and must be routinely and thoroughly performed before the induction of anesthesia.
After pre-oxygenating the patient, the next step is to administer the intravenous anesthetics. The most commonly used intravenous induction agent today is propofol. This drug has a fast onset time and is rapidly eliminated. Thus, patients remain unconscious only for a short period of time when a bolus of this drug is administered. Importantly, propofol can cause pain on injection. To minimize this possibility, anesthesiologists frequently administer lidocaine, a short-acting local anesthetic, immediately before injecting propofol. Other medications commonly given prior to induction include additional midazolam and fentanyl. Midazolam, in addition to allaying apprehension, reduces the anesthetic requirements of other medications, including the inhaled anesthetics. Fentanyl, a potent narcotic, is used prior to induction to blunt the hypertensive response to laryngoscopy and endotracheal intubation. The administration of propofol marks the beginning of induction of general anesthesia, after which the patient is expected to lose consciousness.
As we mentioned earlier, the dosages of the induction agents and the sequence in which they are administered may vary depending on the patient, the anesthesiologist, and the procedure. It is important to understand that when given in sufficient amounts, drugs such as midazolam and fentanyl can serve as the main induction agents. Thus, it is possible, and in fact commonly done in anesthesia for cardiac procedures, to induce general anesthesia with midazolam and fentanyl alone, without administering propofol. In these situations, avoiding propofol may reduce the possibility of hypotension.
Now that you've seen and heard a bit about the various medications involved in the administration of a general anesthetic, you may be wondering, are all anesthetic agents intravenous? And what about patients with difficult intravenous access?
It is important to understand that general anesthesia can be induced with a potent inhalation agent alone, without administering intravenous agents. The commonly used inhalation agents today include sevoflurane, isoflurane, and desflurane. These agents are administered either by face mask or through the endotracheal tube after endotracheal intubation, and are frequently used to maintain the anesthetic after intravenous induction. However, they may also be used in the absence of intravenous agents. The reasons for routine administration of intravenous agents include expediting induction and assuring muscular relaxation during endotracheal intubation.
It is also important to remember that regardless of the type of anesthetic agent used, the induction of anesthesia frequently results in apnea, and the patient requires positive pressure ventilation through a face mask. Ventilating patients with a face mask is an essential skill that all physicians should be familiar with. A rotation in anesthesiology is the best way for a student to learn this valuable skill. After the administration of the induction agents, the next step is to manage the patient's airway. Managing the patient's airway may consist of ventilation with a face mask, insertion of an oral or nasal airway, laryngoscopy, and endotracheal intubation. This is facilitated by the administration of a neuromuscular blocking agent, such as succinylcholine or becuronium. Neuromuscular blocking agents enable airway instrumentation, laryngoscopy, and exposure of the laryngeal structures, as well as endotracheal intubation, to occur without resistance, laryngospasm, or coughing. After injection of the neuromuscular blocking agent, it is necessary to wait until the agent has taken effect before proceeding with endotracheal intubation. If a depolarizing neuromuscular blocking agent, such as succinylcholine, is used, the patient may demonstrate muscular fasciculations, indicating the onset of the neuromuscular blocking effect. However, fasciculations are not always visible and do not occur when using a non-depolarizing neuromuscular agent, such as vecuronium. In either case, it is necessary to determine the onset of action of these medications prior to attempting endotracheal intubation.
The onset and duration of action of these drugs is confirmed with a nerve stimulator, a device which electrically stimulates the nerve and results in muscle contraction in the presence of normal neuromuscular function. The nerve stimulator electrodes are most commonly placed either along the ulnar nerve to monitor the contraction of the adductor pollicis, or on the facial nerve to monitor the contraction of the orbicularis oculi.
Endotracheal intubation is achieved by exposing the glottis using a laryngoscope. The conventional laryngoscope is a left-handed instrument, most commonly fitted with the curved Macintosh blade. Laryngoscope blades are interchangeable, and anesthesiologists can choose from a broad selection of shapes and sizes to best expose the laryngeal structures.
The direct laryngoscopy is performed with the patient's head on a pillow to align the oral cavity with the larynx. While holding the laryngoscope in the left hand, the anesthesiologist opens the mouth using the right hand. Alternatively, an assistant may depress the jaw and open the mouth. The laryngoscope is carefully inserted into the oral cavity on the right side, and the tongue is retracted to the left. The tip of the blade is advanced towards the base of the tongue until the epiglottis is identified. By placing the curved blade in the vallecula and pulling forward and upwards at a 45-degree angle, the epiglottis moves anteriorly, revealing the glottis. The endotracheal tube is then advanced with the right hand into the trachea.
After advancing the endotracheal tube, it is crucial to determine its position. Endotracheal tubes can be unintentionally placed into the esophagus or inadvertently advanced beyond the bifurcation of the trachea into a mainstem bronchus.
Several methods are commonly used to determine the correct position of the endotracheal tube. However, none is infallible. This is why anesthesiologists insist on combining these methods to assure the highest possible degree of certainty. If the tube is in the trachea, ventilation attempts usually result in visible condensation in the tube and chest wall movement. The best indication that the patient is being properly ventilated is the detection of carbon dioxide by the capnogram. However, this method alone does not reliably determine if the endotracheal tube is in the correct position. This is because a capnogram tracing would appear even if the tube were in a mainstem bronchus or in the oropharynx. Another means to corroborate proper tube placement is chest auscultation. If the tube is in the trachea, auscultation of the chest should yield bilateral breath sounds. If, however, the tube is instead in a mainstem bronchus, only unilateral breath sounds would be evident. Similarly, if esophageal intubation has occurred, no breath sounds would be appreciated. However, there are cases in which an esophageal intubation may generate chest sounds resembling ventilation of the lungs and equivocal chest movements. Furthermore, it is possible for the tube to be properly positioned within the trachea, yet due to obesity or severe bronchospasm, breath sounds can be inaudible or absent. This is why it is important to combine the methods to determine the position of the endotracheal tube. The combination yields a greater sensitivity than any method alone.
If the tube is inadvertently placed in a mainstem bronchus, simply withdrawing the tube above the bifurcation of the trachea would resolve the problem. If the tube is in the esophagus, however, it is necessary to remove the tube and use a new endotracheal tube in reattempting the intubation. There are circumstances, however, such as in the case of patients who have recently ingested a meal, where leaving the endotracheal tube in the esophagus while intubating the trachea with another endotracheal tube is appropriate. Even in the case of visualization of the tube within the trachea using a fiber optic instrument, it is possible for the tube to migrate above the glottis or beyond the carina. Therefore, it is imperative to continuously ascertain the correct position of the endotracheal tube throughout the anesthetic. Once the endotracheal tube is secured in proper position and ventilation is reinstituted, the patient is ready for the surgical team. Throughout the entire procedure, an anesthesiologist is present to care for the patient.
The anesthesiologist monitors the patient's skin color, breathing pattern, pulse, pupil size, presence of lacrimation, as well as other variables. Additionally, the anesthesiology uses electrocardiography, pulse oximetry, and peripheral nerve stimulation to assess the patient's hemodynamic and respiratory status, as well as the degree of neuromuscular block throughout the procedure. Recently, electroencephalography has been adapted to aid in determining the depth of anesthesia. Although depth of anesthesia monitors are not currently considered standard of care, some clinicians find them useful in titrating the drugs used during the general anesthetic. Using both clinical skills and monitoring devices, the anesthesia care provider ensures that the patient is adequately anesthetized.
During the administration of a general anesthetic, a patient may undergo several changes in physiology, including hemodynamic, respiratory, and metabolic alterations, among others. These changes can be secondary to the anesthetic, the surgical procedure, an underlying medical condition, or a combination of these factors. Closely monitoring the patient's hemodynamic stability and neuromuscular function during the operation allows the anesthesiologist to detect a problem immediately and respond appropriately to minimize the possibility of complications. For instance, if hypotension develops during the case, it is important to determine the cause. Is it due to the anesthetic? Is there a significant blood loss in the surgical field? Or is the patient developing a myocardial infarction? These are just a few of the questions an anesthesiologist must entertain when faced with this and other similar situations. The hallmark of a good anesthesiologist is to first ponder the cause and rapidly institute treatment if necessary. In spite of modern monitoring developments, most would agree that the senses of a vigilant anesthesiologist are the most important determinant of safety during the administration of a general anesthetic. Remember that prior to intubation of the patient's trachea and throughout the procedure, the anesthesiologist created and maintained a neuromuscular block. Prior to allowing the patient to emerge from anesthesia, it is necessary to restore complete neuromuscular function. This is required for the patient to optimally protect his or her own airway upon awakening. For instance, the coughing mechanism should be intact.
While the effects of all clinically used neuromuscular blocking agents eventually disappear due to biodegradation, the return of normal neuromuscular function can be expedited through competitive antagonism using a cholinesterase inhibitor such as neostigmine. This results in increased presence of acetylcholine, which displaces the neuromuscular blocking agent from the acetylcholine receptor and allows normal muscle contraction to take place. However, this increased cholinergic stimulus can result in bradycardia and excessive secretions. Therefore, an anticholinergic agent such as atropine or glycopyrrolate is generally administered to minimize the muscarinic effects resulting from neostigmine administration.
As you can see, a peripheral nerve stimulator used to assess the degree of neuromuscular block throughout the procedure is particularly useful in this stage to determine the return of normal neuromuscular function. After reversing the neuromuscular block, the anesthesiologist prepares to awaken the patient. The administration of the inhaled or intravenous anesthetic must cease. As these drugs are eliminated or metabolized, the patient approaches emergence. The time required for a patient to fully emerge from a general anesthetic depends on multiple factors, including the administered dose of the inhalation or intravenous anesthetic, the metabolic properties of the specific anesthetic, the duration of anesthetic exposure, and the medical background of the patient. Although some inhalation agents, such as sevoflurane, undergo biodegradation, the majority of these agents are eliminated through exhalation. Therefore, the degree of ventilation can also affect the length of the emergence period.
Emergence from anesthesia is marked by significant hemodynamic and respiratory stresses. It is not uncommon for patients to experience shivering, agitation, blood pressure fluctuations, and coughing. Occasionally, more serious conditions occur, demanding immediate management. These include airway obstruction, delirium, or severe hypertension. The stresses of emergence can be attenuated by a variety of maneuvers. For example, administering beta-blocking agents to treat tachycardia and hypertension, covering the patient with a warm blanket, orienting the patient to place on time, and monitoring the patient for blood pressure changes. It is most important to ensure that the patient is alert and can protect his or her own airway prior to removing the endotracheal tube.
Once the patient's neuromuscular block is completely reversed, and he or she has emerged from the anesthetic, the anesthesiologist prepares to remove the endotracheal tube. Several criteria must be met before proceeding with extubation of the trachea. The patient must be able to lift and hold his or her head off the operating table and have adequate tidal volumes. These assessments, together with the information obtained from using a peripheral nerve stimulator, are important to confirm return of normal neuromuscular function. Other factors unrelated to the neuromuscular block are also important. The patient must have stable vital signs, including a normal or near normal temperature. He or she must be able to follow commands, as well as to be able to breathe spontaneously. If these criteria are not met, the patient may need to remain intubated. After extubation, the patient is ready for transport to the post-anesthesia care unit, also known as the PACU. Much like transporting the patient to the operating room, transporting the patient to the PACU requires constant vigilance and awareness of potential risks. This is because managing the patient's airway, if necessary, would be more difficult. Furthermore, there is less immediate access to medications, equipment, or monitoring devices should complications arise.
As with the transfer of the patient from the stretcher to the operating table, caution must be taken in transferring the patient from the operating table to the hospital bed after surgery. Along with providing safe transfer, it is important to ensure that all patients have a patent airway, adequate ventilation and oxygenation, and hemodynamic stability before leaving the operating room. Additionally, it is crucial to provide supplemental oxygen, both during transport and while in the post-anesthesia care unit, to minimize the possibility of post-operative hypoxia.
As you have seen, transport of the patient to and from the operating room must be done with great care. This is especially true for patients who are unstable or must remain intubated after surgery. These patients require manual ventilation, use of portable monitors to observe hemodynamic parameters, such as the heart rate and blood pressure, as well as the hemoglobin oxygen saturation, throughout the transport period. The anesthesiologist may opt to carry a supply of emergency medications when transporting an unstable patient, should a complication arise en route. After transporting the patient to the PACU, it is the responsibility of the anesthesiologist to give a comprehensive report to the PACU nurse. This report includes describing the patient's preoperative evaluation, the surgical procedure, the relevant intraoperative events, any expected postoperative complications, and any post-anesthesia orders, such as the need for ventilation, transfusion, or additional medication. Commonly, prior to receiving the anesthesiologist's report, the PACU nurse obtains the patient's vital signs, assesses the level of postoperative pain, and connects the patient to monitoring devices in order to continuously observe the vital signs. Postoperative observation in the PACU is a requirement for all patients after general anesthesia, regardless of the type of surgical procedure or the anesthetic agent used. This is because the immediate postoperative period is associated with the potential for various complications.
There are several possible complications during the postoperative period. One common and important postoperative complication is hypoxia. To avoid hypoxia, it is important to provide supplemental oxygen with a face mask to all patients, both during transport and while in the post-anesthesia care unit. To improve oxygenation, one can raise the head of the patient's bed.
The length of time the patient must spend in the PACU varies because the length of time a patient requires to recover from anesthesia differs from patient to patient. Factors that may influence this recovery time include the patient's medical background, the length and type of surgical procedure, the length of exposure to the anesthetic, and the type of anesthetic used. In general, a patient is ready for discharge from the PACU once he or she has stable vital signs for at least 15 minutes, is able to maintain a patent airway, is easily arousable, is fully oriented to place and time, and is capable of calling for help if necessary. Additionally, he or she should have no surgical complications. We hope that this brief explanation has helped you to understand the basic process of administering a general anesthetic. Although you will invariably encounter variations of the techniques described here, mastering this basic process should provide you with the knowledge necessary to understand further more complicated anesthetic administrations. Please keep in mind that while this presentation provides a panoramic overview of the steps involved in the administration of a general anesthetic, it is by no means comprehensive. Each one of the steps described here is simply an illustration and can itself be the subject of extensive review.